So, as I said, I'm Michele Sandelson. I'm the obesity specialist dietitian working at St Bartholomew's Hospital, the obesity service there. I've been there now since 2019. And it's very interesting, Dr. Slee, your presentation, because I'm going to be just explaining how this is working in practice, what's just been explained. So these are my tonitas. You can tell how long our service has been measuring body composition by the age of the one on the right. So this is actually my favourite one. It's really good. It's a real dinosaur, but it's a good workhorse. So these are my two tonitas. I just wanted to show you those. And this is my Maltron, which actually does measure sarcopenia. So it has an index, which the doctors love it very much. So this is my student who I popped on there yesterday so you could see this machine. So we do sometimes have issues around measuring sort of housebound, bedbound patients. Now, I don't really do home visits, but I have done a couple of them on occasion for an emergency kind of patient who the doctors wanted to assess. But I still have my calipers, and I will use those. I have actually an amputee who I use this on because obviously I can't put the probes on him fully, or he can't stand on the comp. So this is quite useful. It would be nice if I could send these Murac tapes to patients, which we kind of do, just so that if they're at home and they're bedbound, we can actually measure any weight loss for the surgeons. If they want to sort of see what the weight loss is, how it's going at home, because we will speak to them on the video, but how do we measure them? So, but unfortunately, the tapes that I have are too small for our patients, so we're working on how we can get around that. So basically, how do I choose which scanner? The Maltron is really useful for assessing fluid. And my tonitas are really useful for assessing the visceral fat levels because my Maltron does not measure that. So generally it's clinical judgment. My doctors will ask me, Michele, please, can you do a Maltron? Can you do a tonita? Or can you do both? Depending on what it is that they want to know. If they have a pacemaker, ICD, CRTD device, we use the Maltron. We don't use the tonita because it says on there you can't. A cardiologist told me, it's the same thing. But anyway, I'm a dietitian humbly, and I will follow those rules. So anybody who can't stand for a minute, then we put them on the Maltron. The wheelchair bound but can transfer to the bed, we'll put them through the Maltron as well. If they're pretty mobile but don't have a cardiac device, we'll just generally use the tonita because the Maltron takes a little bit longer. And to be honest with you, it would be nice if we could do it on both patients, every patient, but we just don't have the time. The tonita is really fast. You pop them on, it's done in minutes. The patients, we do like to put through the Maltron and the tonita together, the heart failure, the Hocum's lymphedema, edema, CKD patients, basically. Okay. So the body composition scans, so obviously every machine has an error. So there will be errors in the data, but it's going to be the same error as long as we're using the same machine. So we will be able to say with quite a lot of certainty if somebody has lost visceral or they've lost fat mass and how much they've lost. We'll be able to give a good idea that that's correct, vaguely, almost. So it really does give the patients motivation, because if they do go away and we give them all the nice exercise links, or they go to an exercise class and they come back and they say, Michele, I have put on 2 kilo, or I haven't changed, nothing's changed, so this is not helping me. And then you pop them on the machine and they will see that they have lost fat mass and gained muscle mass, so it looks like nothing's happened. Okay. So they get very excited and then they go away and continue. So also it leaves them, they have questions for me. So I don't say anything, but I show them the results and they go, oh my goodness me, how can I increase my metabolic rate? And that leads me into say, well, exercise, healthy eating, etc. So they're asking me for that help, which is really nice. So it's a real opportunity to encourage change using the results of these machines, and the patients absolutely love them. So I'm going to show you. So this is what I gather from the data. So the machine does do a few more bits and bobs, but I like these really, and this is what our doctors really like. So you can see here, I wanted to show you this because it's very, what you were saying, this really describes. So this patient, this is a 30-year-old female black British lady with osteoarthritis. She has some anxiety, but generally she's actually quite well. So she's got a BMI of 63.2. But look at the visceral, it says 22. Now, I usually see patients with that level of BMI will be in the 30s, in the 40s. Sometimes this machine will go up to 59 visceral. If it's very high, it might not even record it. So some patients, every now and again, I get a patient who's got maybe a huge abdominal apron, or they're just so large that the machine does not like it. But generally, if you then have a look at this one, so this is my 39-year-old male, who's a British West Indian gentleman. He has OSA, hyperventilation, pulmonary embolism in the past, hypertension, pre-diabetes. If you look, his BMI 49.2, which is significantly less than my last lady, but his visceral level is 30. Yeah. Okay. So let me just check. I'm talking about everything I need. Okay. So I'm going to show you this one as well. This is where I do my follow-up. So really important to do the follow-ups. So the second one, I always say the second one is the most important one. This is where I can really track what's actually happening. So this lady here, I don't know if you can see this, she basically, she wasn't on any medication, but she decided to make a lifestyle change. But as you can see here, of the 10.6 kilos that she lost, basically just over half of that was actually muscle mass loss. So although some of the fat loss was the visceral, it wasn't that much. And the other thing with the basal metabolic rate, you can see it's the same. Now, we would normally see the metabolic rate go up quite slowly with weight loss, but you should have seen like a little bit of a rise in that, and that didn't happen. So now you look at this lady. So this is what we want to see. So this is my 56-year-old female patient. She's on OSA, she's got OSA, she's on CPAP, she's compliant, type 2 diabetes. She has knee pain, long-term obesity, and she started tirzepatide in April. And currently on 7.5 milligram, and we're holding her there. Now, when our patients go on to tirzepatide or Wegovy or Ozempic, we really get them in as soon as we can to do their body composition, because what we need to do is monitor their muscle mass like a hawk. And this lady was a really good result. So she came in just a few days ago, and you can see that she's lost 8 kilos, but only 1.1 kilos of that was muscle. And so that is that for us is a whoopee. We're very pleased. Okay. So I'm going to show you a Maltron case here. So this is my 65-year-old African Caribbean lady with dilated cardiomyopathy, mild systolic impairment, left bundle branch block, first degree HB, a new pacemaker, and type 2 diabetes, and she's on Mounjaro. Okay, and this is what I pick up from the Maltron. The Maltron actually, as well as like the Tanita, does give me quite a lot more, but really in the obesity service, this is the information that we want. So the My Machine is very good for renal patients. In my renal colleagues in the dialysis unit, they will use it because it's obviously, for obvious reasons, very useful for them. See the pre-dialysis, post-dialysis, fluids, etc. But My Machine it gives me the skeletal muscle, it gives me fat-free mass and the body fat, which is very useful, but it does not give me that visceral, which is a bit disappointing. So I provided this lady with dietary advice on good quality protein, reduced carbs and vegetables, strength-based exercises we recommend to every single patient, particularly if they're going on to a GLP-1. They get sent these exercises. I showed them how to do them in clinic, actually. They take 15 minutes, and they're really helpful. And this patient, I will follow up in 3 months and do the scan again and see what's happened. Okay, so this is quite an interesting chap. He's actually a priest, so he has hypertension, hip replacement, OSA, but he's very compliant with CPAP, persistent AF. When he was young, he was diagnosed with a pituitary tumour, and he had surgery for that because he had acromegaly. He has just recently been diagnosed with fatty liver, and I did this Maltron in July. And as you can see here, this concerned me quite a lot. His fluid overload was quite substantial. He had interstitial overload of 7.65 litres. So he is unfortunately out of area patient, but we've alerted the local support that he's under there. But I just found out last week he didn't turn up for the follow-up. And he's messaged me. He's been admitted to hospital, emergency admission with acute confusion, renal failure, liver impairment, infection, and massive fluid overload. But he was in sinus rhythm throughout, according to our cardiologist. So that's it. So he remains in hospital in rehab. So I just thought that, that was interesting that my Maltron picked that up. The other thing it picked up was osteopenia. And I don't know how accurate that is on my machine, so I didn't mention it to the patient. But he then started complaining to me of some MSK pains in his spine. Okay, so the last thing, this is my last slide, which I don't really see very well. So I've developed this spreadsheet, and I've used the Henry equations in the first few columns. So this will let me work out the BMR of the patient, what their energy needs for weight loss. This is what I use. So I use Henry. I used to use Schofield. Now I use Henry. I've also got Mifflin as well that I sometimes have a look at. That comes out quite low. But using this, although it's a guesstimate, obviously, because it's indirect calorimetry, and I haven't got whole body calorimeter. They've got one at the Human Nutrition Research Centre, but I don't. So this is my way of trying to give the patient a goal, a calorie goal for driving weight loss. And they find this quite useful because what I do is I know that with these equations, you usually get about a 15 to 20% plus minus error margin. So the way I see it is if the patient is working towards their BMR and don't go over that, and we take the lower end of that range of that plus minus, then we're getting something which is maybe going to help. At least they've got that target. So they can use apps now. I say to them, maybe go over a 7-day period with, say 9,800 calories a week or 14,000, whatever it is. And that means they can be flexible every day with their food intake because we don't eat the same every day. So we'll work with them if that's what they want to do and they're quite happy doing calorie counting. So thank you very much. That was me. And I hope you found that useful. Thank you.
Thank you.